Good morning, ladies and gentlemen. I am Dr. Clarence Lei, and I am recording this talk pre-recorded for the Borneo Urology Update 2021. But I hope to log in during the day itself so that we can answer some questions live, or we can take on the questions to the email or by the WhatsApp. The topic given to me is, Doctor, I am going to the toilet too frequently, even at night. So what are the topics that I'm going to cover? My lecture outline will be on the latest developments, some real-life experiences, some definitions, investigation or investigations, if any. What about the medications that we have used in the past, any side effects, any new treatment, and what are my preferred choices? So let's have a holistic overview of urinary symptoms. This lecture will be mostly on the bladder, but don't forget we have the prostate, we have the urethra, we have the sphincters, and also the nearby organs, especially urinary stones, especially in the lower ureter, in the rectum, the cervix, and don't forget, all this is controlled by the nervous system and the endocrine system. So all this plays a part in urinary symptoms. Now, the emphasis of this lecture is on urinary frequency, but this is often associated with nocturia, okay, passing urine at night. Also sometimes associated with urinary urgency, urging, and also urge incontinence. So what they call the funny group of symptoms, frequency, urgency, nocturia, incontinence. Now I show a case which was referred to me way back in 2018. This is a 32-year-old mother of 2 girls delivered by spontaneous vaginal delivery 8 years ago, and the last one by cesarean section. And the referring doctor said frequency, nocturia more than 10 times, urine FEME, NAD. And what is his diagnosis? OAB, overactive bladder, refer Dr. C. Lei. So actually there is a lot of community awareness among the doctors on this condition called OAB. Now what is OAB? OAB is defined by the International Continence Society as urinary urgency with or without urinary incontinence associated with frequency of more than 8 times per day and nocturia at least once at night. And apparently urgency is the only symptom that is important in making a diagnosis of OAB. And if there any urinary loss, it's called urge urinary incontinence. Bear in mind, this is a diagnosis of exclusion. There should be no associated pathological coexistence of things like bladder tumor, bladder stones, neuropathic bladder. But you can also have OAB and subsequently develop an associated problem like cancer cervix, bladder carcinoma in situ, or some gastrointestinal problems like the rectal cancer. So this is the scientific basis of the condition called OAB. When you take a history from the patient, you have to go into the lifestyle modifications for coping with the symptom. For example, they limit their travel, or they travel, wherever they travel, they need to know where are the toilets, they control their fluid before they go for traveling, and of course some of them may be even wearing urinary diapers to cope with the incontinence or suspected or expected incontinence. In my practice, I find that OAB is often associated with non-urological symptoms, for example, IBS, gynecological problems, PV bleeding, and sometimes psychosocial problems. And in women especially, one Swedish studies found that many of them have associated migraine, asthma, pelvic pain. So it may be that OAB is actually part of a spectrum of disease pathology. It is actually a systemic cause of symptoms. Now, how do we treat OAB in the past? We give them a medication to stop contraction of the bladder muscle, the detrusor muscle, what's called anticholinergic, specifically an antimuscarinic. But we also know that the cholinergic fibers are found throughout the body. So the side effects you can imagine would be constipation, dyspepsia, tachycardia, and especially dry mouth, dry eyes, blurred vision. So it's definitely contraindicated in glaucoma, and the cholinergic fibers are also in the central nervous system. So this can have an effect on cognitive function. So it's no wonder that the medications that we previously used, the so-called anticholinergics, especially oxybutynin. Oxybutynin has been used for a long time, way back in 1970s, and even now it's still used. It can also be given in pediatrics, also can be given into the bladder, especially if the patient is already on clean intermittent catheterization. If you go to some of the airports in the world, you can even buy oxybutynin transdermal. The newer formulations include tolterodine, solifenacin, commonly known as Vesicare, Prospion, and darifenacin. All these drugs are so-called anticholinergics. They stop the bladder contraction. Okay, another drug which is often used, especially by the neurologists and some rehab physicians, is that of amitriptyline, and this is especially useful if the patient also have some associated pain and anxiety. They have a sedative potential, so you have to start the medication low dose, slowly titrating it over a period of a few months. So these are the drugs that were previously available for treatment of anticholinergics, but they have many side effects. So one other important side effect, which I haven't mentioned earlier, is from this patient. He sent me a WhatsApp. He said, "Doctor, kalau mau traveling, saya kencing sangkut. So if he takes the medication, he has difficulty in passing urine, even with the risk of acute urinary retention. So if you give it to patients who have difficulty passing urine, they have a risk of acute urinary retention. The other side effect is nowadays is increasingly recognized. And one such patient, the daughter is from Australia. He came back to Kuching and he got stuck in Kuching because of the COVID pandemic. And he said, my father can hardly recognize me. And she went through all the medications. And all of these medications seem to have some kind of effect on the cognitive function. He said, no wonder my father is taking your medication for his urinary frequency. No wonder he cannot recognize me. So these drugs have an effect on cognitive function, especially in the elderly who are already on polypharmacy. What about in children? If you give it to children, the anticholinergics can have an effect on their central system. And one such mother said, oh, my child becomes very active in the school. But I suspect these children probably already have a predisposition to behavioral problems. So these are the many side effects you can have from anticholinergics. So it's not surprising me that in a study done in the UK, in the National Health Service, where medication are given free of charge, at 12 months, only 30% of patients, 30% of patients are so-called compliant or persistent with the medication to OAB. And a similar study done in Canada, also similar results. And in fact, my good friend Malcolm Lucas, he presented in the European Association that actually at 3 months, already 50% of patients have already stopped the medication, not because of financial reasons, but because of ineffectiveness or side effects. So this is how these anticholinergics work. They work on this side of the anti-muscarinic receptors. But now we have another medication which works on the adrenergic side. So the adrenergic receptors, the adrenergic receptor agonist. The name of the drug is called mirabegron. It works also by relaxing the bladder muscle without an anticholinergic effect. So this can also be used. This bladder medication can also be used to reduce frequency. And so it doesn't have the anticholinergic side effects. And I look at my own patient data, which over a period of about a year, and I have got 66 patients, and most of them are male patients. Mainly partly because I'm a urologist, and the female patients in Malaysia tend to go and see a gynecologist. And children, I also use it quite a few children, especially the children who have got wet OAB. In other words, the patients have got urinary urgency with urge incontinence. But as it is now, many of the medications are used off-label. In other words, there are no studies done on the safety in children. There are no studies done. Most of the patients that I use medications on for urinary frequency are in the elderly patients. Elderly means above 65, older than me. Okay, so because it's not an anticholinergic, the adherence to the medication at 1 year is much higher, at 65%. At 3 years, it's still 46%. So this medication is just as efficacious as the anticholinergic or antimuscarinic, but they have got less side effects. Now, what about if the patient symptoms are not completely relieved by a beta-3 agonist? You can add on as well anticholinergic medication. So this one is called dual therapy, because this is effective because they've got a different mechanism of action. And these are again being published, proven to be effective and safe. What about patients who have many other kinds of symptoms? For example, this patient, which was seen at the government clinic in 2017. So most of the doctors know very well about the prostate. They know very well about IPSS score, International Prostate Symptom Score. And he did the International Prostate Symptom Score on this patient. And he found that this patient has got incomplete emptying, as well as some frequency, intermittency, urgency, but no weak stream, 0. The score for weak stream is 0. And it doesn't have the strain. Nocturia just once. So this seems to be a predominant storage symptom, predominantly more diagnosis of OAB, overactive bladder. Okay, and he's very good. He has also ruled out diabetes. And so he diagnosed this patient probably as OAB, but he went and discussed with somebody else, discussed with doctor, I think FMS is a family medical specialist, family physician. And for some reason, instead of giving a medication for OAB, he was given an alpha blocker, tarajosin 1 milligram, very low dose for 3 weeks. I suppose he intended to titrate it to 2 milligrams and then maybe eventually 4 milligrams or 5 milligrams. So this patient is given the medication for benign prostatic obstruction instead of OAB. But is he giving the right treatment? At the first impression, maybe not. Maybe given the wrong treatment. So not every patient presenting with symptoms has got required prostatic medication. So this is obviously giving the wrong medication. The patient did not respond to treatment. But this is part one of the story, not the end of the story. Okay, we can discuss later on. So these are the patients who have got underlying BPH. They have got benign prostatic hyperplasia giving rise to obstruction. So these patients, if you give them an alpha blocker like tarajosin or tamsulosin, they can pass urine better. And in fact, I think for some of them, the OAB symptoms can improve. For some of them, mainly about 50%. So in fact, the previous patient, if I can go backwards, in fact, this patient, the symptoms may improve if he has got underlying obstructive symptoms. Bear in mind, the patient said the urine stream is good, but bear in mind that the bladder is a poor weakness. So it may be that he has got poor urine stream. It may be that he will improve. So there's a part 2 of the story of giving an alpha blocker to somebody with OAB symptoms. This is another patient. This patient, his main concern is that he has got nocturia and urgency. He's not worried about the flow, but when he actually measured the urine flow, his urine flow is poor. And so he was given an alpha blocker. And he went on to see his urologist, who said, look here, your flow is very bad. Let me do a TRP on him. So he had a TRP done and his urine flow is excellent. But patient is not happy. Why is he not happy? Because his symptoms, which he is concerned, the nocturia, the urgency, the urge incontinence, became worse. So in actual fact, we must look at what are the patient's symptoms. The symptoms may be worse after a TRP. Of course, this patient requires treatment for his OAB as well. So these are the symptoms that you can tease out in a patient with LUTS. So let's talk about medications in Sarawak or in Malaysia. In Malaysia, talk about Malaysia. So how long do people take the OAB medications? How long to take it? So they say, okay, if I take an alpha blocker like anal or tamsulosin, I can pass urine within hours. What about this medication for OAB, for example, by Miga or Vesicare? Well, actually, the onset of action is within few hours. So I said that it can actually work within days. So if the medication works within days, then how long do I take the medication? Why can't I just buy 1 week supply? No, I just buy 1 week supply and see whether it works. My answer, and actually I discussed this with my colleagues in Kuching, we've got a very close group of urologists, is that, well, when you take medications for urinary symptoms, it's ideally you take it for a month or 1 box. According to the pharmacy, they only sell 1 box. This is because actually urinary symptoms depend very much on other factors like your diet, your sleep, how much sugar you take, how much salt you take. So usually for maximal effect, it takes the body some time to adjust to see whether it's effective or not. Usually, so I say you take it for a month. Now, how long you take the medications? You take the medications forever. If you tell a patient that you take the medication forever, most of them will say, oh, no, let's forget about it. I'm not going to take medications. But in actual fact, when you take medications, the symptoms may improve. At the same time, if you improve your lifestyle, your symptoms may improve. In fact, I would think that maybe about 1/3 of the symptoms, lower interest symptoms, will improve spontaneously if you improve your lifestyle. And another 1/3 of them may be stable. And only 1/3 of the symptoms will get worse. So I think it's not true that urinary symptoms are progressive and you'll take medication for life. And this is the evidence from, well, case study evidence. My sister is all good now. So they've given them the medication and they improve and they don't need to take the medication for a long time. Of course, if the symptoms recur, they take the medication again. So this is why it's called intermittent therapy for urinary symptoms. Now, as a family doctor or as a general doctor, non-urologist, when do you refer the patients? We had a meeting in 27 November where I met with 4 non-urologists and we discussed all the possible conditions giving rise to frequency nocturia. And these are the red flags that you have to refer a patient for specialist evaluation. So if you have blood in the urine, if you have pain, if there history of taking medications like ketamine, which can affect the bladder function, bladder, kidney, and liver function. Ketamine is used as a recreational substance nowadays in many parts of Asia. And if you have the underlying condition called interstitial cystitis, if the patient have any form of neurology, like fecal incontinence, lower limb weakness, numbness, back pain, any neurology, or if they've taken the medication for a few months and with no effect. And of course, in elderly people, we try to avoid too many medication. And we also try to see whether the patient have an underlying tumor like carcinoma in situ of the bladder, cancer of cervix, cancer of the rectum, any pelvic tumors. So if there's any concern about these conditions, then you should refer the patient for a specialist evaluation. Of course, after that, we can always send the patient back to the family doctor. Now, the second subtopic given to me is that of nocturia. And bear in mind, first of all, nocturia means passing urine once at night or more than once at night. This is different from primary nocturnal enuresis in children, where they still continue to wet the bed after the age of 4 years. Okay, so this is a completely different condition. And there are many, many factors. One factor is primary nocturnal polyuria. In other words, they produce a lot of urine at night. Okay, so that is one condition. Then, of course, you've got diabetes mellitus. If the sugar is sky high at night, of course, they produce a lot of urine. Diabetes insipidus, not so common, but it's there. And then we have got patients who have got menopause, patients who have got prostatic problems, they cannot empty the bladder well, and they also wake up many times to try to empty the bladder. And also we got heart failure patients, when they lie down, the fluid returns to the body, they have diuresis at night. And there are another group of patients or psychological problems, cannot sleep at night. So these two psychological group of patients, is the treatment is psychological. For example, this condition called primary polydipsia. Many people keep a bottle of water next to the bed, and every time they wake up, they drink one big glass. So of course they've got a lot of urination at night. So this is topic of nocturia. It's a complicated topic. It's the most common symptom that you can find in patients who coming to see you with lower tract symptoms. Now, what is the aim of the treatment of nocturia? The aim is not to stop the urination or to stop the production of urine, because the patients become dehydrated, or if you stop the urination, they continue to drink, they get fluid overload, and of course there are a lot of side effects from the medication. So actually the idea is to increase the time of the sleep, the first voiding, to about 5 hours. Why? Because it is the most important is that 5 hours of sleep is important for the rapid eye movement sleep, which give them quality sleep. Okay, so that is the idea, not to stop the urination at night. Now, what about some of the lifestyle or non-pharmacological methods to reduce nocturia? One is to reduce the drink 4 hours before sleep. Of course, if you go for a nice dinner, take alcohol, you take sweet drinks, take a lot of salty food, of course you'll pass urine at night. And some people, I don't do it myself, but some doctors give the patient a diuretic in the late afternoon so that they empty the excess fluid. Some people advise compression dressing, like this, compression dressing, which you can buy from most of the pharmacies. And the idea, I think many people also use it when they go on long flights. The idea is to compress the lower limb so that the fluid do not collect in the lower limb. Or you can lie down in the afternoon to elevate the legs, but not to lie down and sleep. Because if you sleep in the afternoon, you cannot sleep at night. Then you have to wake up to pass urine. So these are the non-pharmacological lifestyle changes which I advocate to reduce nocturia. And then what about medication? There's a medication called Urinary. Is desmopressin, and it's used for patients with diabetes insipidus, for primary nocturnal enuresis. This is the tablet form, 0.1, 0.2 milligrams. This is not the medication to use for nocturia. The medication for nocturia is a sublingual form. You don't have to drink water with it. It is available in Malaysia at 60 micrograms. Very different dosage, 60 micrograms and 0.1 and 0.2 milligrams. Completely different. It's sublingual. Why do we use a lower dosage? Because if you take a higher dosage, there's a high risk of hyponatremia, especially patients who are already predisposed to hyponatremia. If they are elderly, if they are female, if they are on diuretics, if they are on medications. Many medications can cause hyponatremia, including SSRIs, antiepileptics. So this medication, desmopressin, is an antidiuretic hormone. Take it sublingual. It will reduce the amount of urine produced at night so that they can have good sleep And they have a newer formulation, 25 to 50 micrograms. It's not available in Malaysia yet. So this is a new drug which can help to improve the sleep and the quality of life for elderly patients who have got bothersome nocturia. Now, what's the danger of desmopressin or Minorin? The most serious complication is that of hyponatremia. So therefore, you must check the serum sodium before you start 3 days, 7 days, and 30 days. And if the sodium is low meaning less than 130, then you have to stop the medication and replace it slowly. Do not replace it very fast, because if you replace fast, then you have got central pontine myelitis. It means the patient can become permanently paralyzed if you suddenly replace the serum sodium with intravenous sodium. And you have to be careful in this age group of patients, the patients who are more than 65, female, on multiple drugs. You have to be very careful with this group of patients. But otherwise, to me, this medication, desmopressin, sublingual, low dose, is a game changer for patients with bothersome nocturia. So this gives me to the end of my presentation on urinary frequency and covering also nocturia as well. Thank you so much. I'll be happy to take questions either by live Q&A or by email and WhatsApp. Thank you for your attention.